Yes, we've got a great show. And thanks to those of you who contacted me by phone, email, survey, telling me of topics you're interested in. And Lorraine, a special shout out to you for recommending this topic on a new device from Abbott. You know, since COVID pandemic began and it's not considered safe or wise to meet in person until vaccinated, we, like many organizations, adapted to the new environment and added a new method of communicating through computer Zoom meetings. Thanks for joining us. The benefits, I think, have been surprising. Through these computer meetings, we've been able to just turn on the computer in our own homes. No traffic, no parking problems, no BART ride or carpool to get to the meetings. And we've visited with local cardiologists, podiatrists, respiratory therapists, doctors, nurses, medical educators, caregivers. And last month, we branched out with a visit from the executive director of National Mended Hearts, Andrea Baer, who is in Pennsylvania. And she took us on a tour of their new website, which is now populated with some of the most instructive, riveting webinars I have ever experienced. They have been able to pull talent from around the country to explain medical conditions, procedures, devices, and new advances, all about conditions that pertain to the heart. I've become a much more informed patient thanks to these webinars and can spend my $600 visit to my cardiologist asking much better questions. We're going to replay one of these free webinars in their series called In Control, Empowering Patients to Take Control of Their Heart Failure. Webinar 1, which is what's new in heart failure, we will learn not only the basics about what heart failure is, but through the personal experience of our speaker, Tracy DeMars, and her husband, who has coronary artery disease, we will hear how important it is for each of us to be informed about new developments, and if necessary, to keep looking to find the right doctor who is aware of new developments in medical equipment and procedures. In this webinar, Andrea Baer will give an introduction, then Tracy DeMars will speak for 25 minutes, and there is a Q&A section for about another 25. If you have questions about this talk, you can write them in our chat section, and I will send them to Andrea Baer, who told me that she will forward them to Tracy for answers. I'm going to model how you can find these webinars for yourself on your computers. So if I can, I will share my screen and we'll begin. Okay. Does everybody see the Mended Hearts window?
Yes.
Yes.
Okay, good. So what I'm looking at is I'm using the browser Firefox, and up here in the box, I've put mendedhearts.org. This is their amazing website. And I'm going to skip all of these great things and go right to the search thing and type in control. It is important to know that the title so that you can go right to it. And so search results, In Control 2021 webinar series. And webinar number 1 is the one we're going to watch. Look just here at the presentation handouts. You can get handouts, which include the PowerPoint things, the slides that she talks about. So you click on the replay here.
Over the age of 50, cheese can leave a permanent mark on the brain.
Okay, this is an ad, alas. So you can, I think, you can skip that. Let's see. Skip ads. All right.
Good afternoon, everybody, and welcome to the webinar. Today, we are so excited because we are kicking off our Stay in Control series, which is empowering patients to take control of their heart failure. This is our second in our In Control series, building off of the 2020 series, which was very popular, and we learned so much during that series. We wanted to take another look at heart failure and see what we could deep dive into and learn about. So this year we are kicking off the series today with the topic of what is new in heart failure. So what patients need to know about how we measure and manage heart failure today. Before we start, and if you're new to us, I just wanted to introduce you to Mended Hearts. Our mission is to inspire hope and improve the quality of life for heart patients and their families through ongoing peer-to-peer support, education, and advocacy. You can find us all over social media now, thanks to COVID. We are not only online at mendedhearts.org and mendedlittlehearts.org, but we have a brand new website called myheartvisit.org, which allows you to connect to patients and caregivers across the nation in a variety of ways. So you can reach them by telephone, text, email, and video. We are also on the social media, YouTube, Twitter, LinkedIn, Snapchat, you name it, we are there. So before we begin, I just want to give a couple of little updates. All attendees are in listen-only mode. So if you cannot hear, hopefully you can see the slides. Check the audio button on your personal computer to assure the sound is on. That is typically the issue. Please type your questions into the Q&A section of the webinar at any time during the presentation. The moderator will read your questions during the question and answer period, but you don't have to wait to put your question in. We will answer them as they come in at the end. And then finally, a PDF version of the slides, as well as a recording of this presentation and all of the handouts, which are in chat now, will be available following the event on our website. So now I'd like to introduce to you our lovely speaker for the day, Tracy DeMars. Tracy is currently with the Integrated Heart Failure Solutions team at Abbott, building education programs. So she is trained as heart failure nurse, and she has treated patients of all ages, including her work with the transplant team at the University of Minnesota. I am going to let Tracy give us some more background on her and get started. I am Andrea Baer, the Executive Director here at Mended Hearts. And Tracy, hopefully I can pass over the remote to you.
Hi, everyone. I'm really excited to be here today and to participate in this education. As Andrea said, I have about 30 years, which is a little scary to think about, of time working in various components of heart failure medicine. As Andrea said, I most recently took care of heart failure patients, pediatric patients at the University of Minnesota in pediatric heart transplant. But heart failure has really always been my passion, and that is why I moved over to Abbott, which is a company that makes a lot of new and innovative solutions and devices to help treat heart and heart failure patients. But more importantly, I think I come to you today with a newer role in my life, which is that as a caregiver of somebody who's living with coronary artery disease. Just 2 years ago, my 51-year-old husband, healthy man, had his first heart attack. Completely shocking to us. He had absolutely no risk factors except for his hidden, unknown, genetic, likely coronary artery disease that has turned out to be pretty severe. So I sort of fall into the same camp as many of you with, balancing life and heart disease and trying to figure out what is the right next step and what's out there and advocating for myself for our family and for my husband and being a support to him. And so really today, I want to share with you some of the very new things that Abbott is bringing to the heart failure space, but just in general, some tidbits that I've learned along the way that I hope will be helpful for you. At the beginning of this presentation, we'll go through some heart failure basics so that we can all be on the same page. And if it's a little basic for you, please stay tuned because I will get into our more advanced topics as the conversation goes today. I'm not sure if I can advance the slides. I'm not seeing that I have that control, Andrea. So if you could go to the next slide. All right, one more, please. All right, so as I said, here's some of the basics. So heart failure is a long-term condition. This is where your heart muscle isn't able to pump enough blood to get to your body, to get the oxygen that your muscles need to function. There's two kinds of heart failure, and we're going to spend a lot of time talking about that today. One of the types of heart failure is when your heart is too weak to pump enough blood, and the other is when your heart is too stiff to pump enough blood. And what happens in both circumstances is that fluid builds up. Heart failure, as you probably well know, is very challenging to treat for clinicians, and it's challenging for patients to live with. It's a progressive disease. Unfortunately, it's not going to get better. So we really need to be informed and updated as to what's out there so that we can keep the heart failure at bay as long as possible and be living as full a life as possible. And I think the most exciting news is that in 2021, in our era of innovation, that there are a lot of treatment options that can help you or your loved one live a really full life with heart failure. Next slide. But you're not alone. Look at the statistics here. 6.5 million adults in the United States have heart failure. And, about 600,000 patients have an advanced form of heart failure. And we're going to go into that and find out where you fall on that range of patients who live with heart failure. So, and also just look at the number of deaths each year that are attributed to heart failure, 350,000. It's staggering. It is a crisis right now. And I'm excited that you're here to hear how you can get a hold of the heart failure that you're living with. So each time that you have a heart failure hospitalization, it's a really big deal. So if you look at my little graph here on the right-hand side of this slide, this green line sort of starts out with your baseline, and then you have a heart failure hospitalization. Your doctor tries to tune you up. Maybe they give you some diuretics and change your medications a little bit. But if you'll notice, the line never goes back to your baseline. And this is how heart failure works. So each time you're hospitalized, your heart is damaged, and it can contribute to your heart failure getting a lot worse. So every time you're hospitalized for a heart failure exacerbation episode, it really is a strong predictor that things are getting worse and it's time for you to take some action. Next slide. So what are some of the things that cause heart failure? So like I said, my husband has really bad coronary artery disease. He's already had one heart attack. And so that is one of the huge risk factors of heart failure is having heart attacks. But also it can be caused by untreated high blood pressure, abnormal heart rhythms. So if you have atrial fibrillation, this could be attributing and causing some heart failure. Heart valve disease, congenital or being born with a heart disease, having diabetes that isn't controlled. And then sometimes it's just caused by an infection of the heart that causes damage to the muscle. So what are some of the symptoms of heart failure? So do any of these cause problems for you? So are you tired or fatigued all the time? Do you have nausea, or do you have sort of a decreased appetite, get really full really fast? Maybe you notice that you have a rapid heart rate. I think some of the really cardinal signs of heart failure that it's getting worse are that you're short of breath, even when you're just walking or doing some simple activities that you used to be able to do without any problem. With that, usually you'll have trouble breathing while laying flat, maybe some swelling or a dry, hacky cough with it. Sometimes patients start to feel like they're a little confused, or maybe they're lightheaded. Or that they're gaining weight, particularly if you're gaining weight and swelling in your abdomen or in your ankles. Those are a lot of the cardinal symptoms of heart failure and something that you should talk to your doctor about if you're experiencing any of these things. Next slide. So here is the most important thing. So one of the things I want to share a little bit about my husband's journey and my personal journey. So I shared with you that he had a heart attack. It was really interesting. Right after he had his heart attack, they sent him off to cardiac rehab. And essentially, we kind of felt like he had a little pat on the back and they said, all right, well, we'll see you at your next heart attack. Well, that wasn't good enough for us. We really wanted to get involved and take control where we could in his heart care. And so we sought out a new doctor, somebody who would help us to know what we could do to prevent his heart failure from or his heart getting worse, or prevent his next heart attack rather than just waiting for it. So we sought out a new doctor who really has encouraged my husband to increase his exercise and his daily activity, to eat a healthier diet. He is absolutely on track with taking his medications as prescribed. And if he has problems with any of the medications, he's been really great about corresponding with his doctor to get something that works for him if something's not working. And of course, if you're smoking, you really do need to stop smoking if you have heart disease. It's absolutely imperative. It is so bad for your heart. Next slide. So this congestion that we talked about swelling in the abdomen or swelling in the legs, or that swelling that causes the shortness of breath that you experience. So it could be due to your diet. Maybe you're eating a bit too much salt. It could be caused because maybe your medications aren't at the level where they need to be, or if you've missed some medications. If you have a sedentary lifestyle, all of these things might result in your heart failure getting to the point that you need to be hospitalized. And as we said earlier, that it's not only expensive to be hospitalized, but oftentimes it's avoidable. And we just talked about how bad it is and what a bad sign it is when you are hospitalized. So some of the tools that we've had or that doctors are using today that feel a little archaic are the fact that we're weighing ourselves every day and that we're taking blood pressures to manage heart failure. These are usually signals that occur pretty late in the process when heart failure is getting worse. And so we're going to talk a little bit about some tools that are a little bit more up to date and really can predict when heart failure is getting worse long before you're just about ready to go into the hospital, and oftentimes before you're even experiencing symptoms. So this is where I wanted to talk with you about the differences in the two types of heart failure. So pay attention here, and I want you to think about where you fall in either of these types of heart failure. Maybe you already know because your doctor has told you, but we're going to go through a tool that is available now to help you understand what's available for your type of heart failure and also where you are on the heart failure continuum. So we're going to go through a couple of slides to sort of set up that tool. And this is the first one. So heart failure with preserved ejection fraction. So this means that your heart muscle is contracting normally. But if you look at the pink or salmon colored ventricle in this slide, you can see how thick it is. And because it's so thick, it's making the chamber or the area of the heart where the blood can go into really small, which means that even though the heart muscle is contracting, it's just not relaxing as it should. So the blood can't fill into the ventricle or into that chamber as much. So if you've been told that you have a stiff heart or a thickened wall, then you would be considered a patient who has preserved ejection fraction heart failure. So heart failure with reduced ejection fraction, this is when your heart muscle gets kind of thin. If you can see in the diagram all the way over to the right compared to the normal heart in this picture, you can see how thin that ventricle is. And because the muscle is so thin, it can't squeeze effectively to get that blood out of the heart into the body where it needs to go. And so this type of heart failure would be called reduced ejection fraction heart failure. So think about if your doctor has told you which one of those you fall into. And if you haven't been told, ask, what kind of heart failure do I have? Preserved or reduced ejection fraction. Next slide. All right, what is ejection fraction? So the ejection fraction is really important because this is the amount of blood that's in your heart that is pumped out to the body. So our hearts don't pump out all of the blood with every heartbeat. They pump out a percentage of blood. And so in a normal heart, your heart would pump out about 50 to 70% of the blood. So when your heart is really thick or really big and the walls are stretched really thin, you can imagine that the heart just can't pump that blood out. It's not strong enough, and it's very big, and it just can't get the strength or the muscle to contract enough to pump out all of that blood. So with reduced ejection fraction, it's really anything under 50%. So borderline would be 41 to 49. But if your heart is only pumping out 40% or less of that blood volume, that would fall into that camp of reduced ejection fraction heart failure, which is as one of the types. But in the preserved type, where your heart is thick, you may still be getting have a normal ejection fraction. It's just that because that ventricle is so small, it's not pumping out enough blood to your body. So you can see that there's a big difference between the two, and it's really important to know which kind of heart failure you have. Next slide. All right. So this is the last sort of tee up slide to my tool that I talked about that we're going to go through. So this is the progression of heart failure. So this is a very typical classification system that most cardiologists use to put patients on the continuum of heart failure. So we know that heart failure starts, you probably have very limited symptoms. You're really be able to live your life. Maybe you even have a little bit of shortness of breath, but you are still living life pretty well. This would be considered class 1 heart failure. So as heart failure progresses, because it's a progressive disease, soon you will start having maybe some limitations of physical activity. You're comfortable when you're resting, but ordinary activity, like maybe walking up the steps or walking to go get the mail, causes a little bit of shortness of breath. That would be considered class 2 heart failure. As heart failure continues to progress, this is when patients start having a lot of limitations in physical activity. Maybe you have to take rests just to go get the mail, or really going to the mall or going to get groceries is more than you can handle because it's just too much walking and you get too short of breath. So less than ordinary activities result in you feeling really tired and short of breath. This would be considered class 3 heart failure. And then the end stage heart failure really is when patients are not really able to do much of anything without being very uncomfortable. You probably spend a lot of time in your recliner. You probably have to sleep propped up on pillows, and you're tired and short of breath even when you're sitting in that chair, and you just are really never comfortable. That would be considered class 4 heart failure. So as I go through those, I want you to think about, where do you fall on that classification system? All right, so now let's get into the management options. What can we do about heart failure? So we talked about lifestyle changes. This is imperative no matter where you are on the continuum of heart failure. Exercise, diet, stop smoking, maintaining a healthy weight. All of these things will help to keep your symptoms at bay and prevent your heart failure from getting worse. Now, medications. Taking your medications as directed. If they're making you feel icky, then you need to talk to your doctor about it, because they can optimize those medications. So let's talk about some of the devices that are available. So an implantable cardiac defibrillator, or sometimes known as an ICD, is used to monitor your heart for potentially dangerous heart rhythms. It really allows your clinician to intervene earlier by communicating relevant events. So if you have an event in your heart or some sort of an arrhythmia, it will communicate that to your doctor. Cardiac resynchronization therapy, and sometimes there's a defibrillator or a pacemaker associated with this. This restores the coordinated pumping between the two sides of your heart. Sometimes if your heart gets really big, it can't coordinate that pumping like it should. And so this device helps to coordinate that pumping, so the blood is going into the ventricle and coming out as it should, and it's not sort of this disorganized pumping. It helps. This is really effective. One of the things that it's been proven to do is reduce those hospitalizations that we talked about earlier, with a 22% reduction in heart failure hospitalizations in patients who had this device. So some of the other things that can happen as the heart gets too big is that because it's stretched really thick, really wide, the valves don't close as they should. So now what happens is there's blood sort of flowing back and forth between the top chamber of the heart and the bottom chamber of the heart because the valves don't close together like they used to. And so really this is so important and has been proven to reduce mortality in patients by simply going in and having that valve closed. And there are devices available to close that valve up like it used to. PA pressure monitoring, there's really only one system that's available on the market right now. It is made by Abbott, and we're going to talk a little bit more about it in a future slide. But it's called CardioMEMS, and what CardioMEMS does is it is a wireless monitor that goes into the pulmonary artery, and it measures the pressures in your pulmonary artery so that your doctor can detect when your fluid levels are going up much sooner than, say, doing a weight or taking a blood pressure. This has been proven to reduce heart failure hospitalizations by 57%. So remember, we talked about heart failure hospitalizations really decreasing the mortality in patients and making your heart failure worse. So this is a really novel and exciting device that actually is available for both types of heart failure. And finally, the left ventricular assist device is a pump. When patients are towards the advanced stages of heart failure, sometimes they just need to have that extra help with a heart pump to go into the left ventricle and really assist in circulating the blood around the body. Excitingly, patients who have been so sick with heart failure, when they have this advanced of a disease, they see that 79% of patients go all the way back to a New York Heart Association 1 or 2. So that's when patients are really living life, doing what they want to, and the left ventricular assist device is able to allow patients to get back to doing that. So you can see these exciting innovations that have come around that are available to patients with heart failure. All right, so here's the tool I talked about. So we're going to put it all together now, and let's figure out, following these steps, what the management options might be for where you are on the continuum of heart failure. So step one, which we already talked about, is to figure out where are you in the New York Heart Association classification system. So are you still able to do almost everything you were before? Are you really having a little bit of shortness of breath when you're running up the steps, or you're carrying a load of laundry more so than you used to? Are you pretty significantly impacted where even mild exercises are causing you to have to pause, maybe take a seat to catch your breath? Or are you spending your day in your lazy boy because it's just simply too hard to get about and do the things that you like to do? And I just put on that slide one thing, if you could go back, Andrea, is that if at any time during any part of your journey with heart failure that you have a hospitalization for heart failure, it's really important that you talk to your doctor about what some of these advanced treatments might be and are available to you. And so let's look at that in the next slide. All right, so step two, now you've identified where you are on that top row. Step two is to really determine, do you feel like you have been diagnosed with preserved ejection fraction, which is that stiff heart, or have you been diagnosed with the reduced ejection fraction where your ejection fraction is low, your heart's not pumping out enough blood? So if you have a stiff heart, you're in the top section here. And if you have reduced ejection fraction, you are in the lower section. So I'm going to go through them each individually to talk about the options that are available for each type of heart failure. So if you are one of the patients with a stiff heart, most importantly, across every part of your heart failure management will be medications to control blood pressure and diuretics. They will be prescribing for those for you every step of the way. And you can see that as you enter into the heart failure where you have pretty significant limitations, Really, the only thing that's available for patients with preserved ejection fraction outside of medications is pulmonary artery pressure monitoring or cardiomems. And there are about 50 to 60% of patients living with heart failure that have this type of heart failure and historically have only had really diuretics and medications to help them. So because medications and diuretics are all that there is to offer, it's absolutely imperative that your doctors understand exactly where your heart failure is. And that's what this device allows, is for them to be able to see long before you have symptoms where your heart failure is at and treat it and do little tiny medication changes and avoid you going into the hospital. So now let's look at the second line. So this is heart failure with reduced ejection fraction. About 40 to 50% of patients have this type of heart failure. But there's a lot more options available in terms of devices for this type of heart failure. So if you are in that bucket where you're still doing pretty good and you're able to go about your day, but maybe you're having some arrhythmias, it might be important for you to talk to your doctor about getting an ICD. In class 2 heart failure, where patients are starting to have some restriction in their activities and you are in this group of reduced ejection fraction patients, this is where a doctor might say, if you are appropriate for this, that maybe you need to have that coordinated pumping again with a CRT device. Again, for reduced ejection fraction, PA pressure monitoring is absolutely warranted in this group of patients as well, because the doctor can have such visibility to what's going on with your heart failure so soon before your heart failure gets worse. And then also with reduced ejection fraction patients, the left ventricular assist device, or the pump that we talked about, is something that this group of patients can have, but also heart transplant is available for patients who have reduced ejection fraction heart failure. So you can see there's a big difference in the way the two types of heart failure are treated. And that's why it's so important to know which type that you have so that you're informed. We will be sharing this tool with you in the coming days. And so be on the lookout for it. I think it's an exciting and neat way for you to do some exploration around what's available for your type of heart failure. I think we can go on to the next slide, Andrea. So I told you that I wanted to talk a little bit about the cardiomems device, because this is something that is available for both types of heart failure. And I wanted to show you how it works. So let's start over here in the green section. So what you're looking at is a span of days. So the bar here represents going from green to red. It represents day 1 to day 30. So, and what day 30 represents is your heart failure got so bad over the last 30 days that you ended up having to be hospitalized. Okay. So let's go back 30 days when this started. So your heart failure is stable and your symptoms are controlled. Maybe you're out doing your thing, you're playing golf, you're doing whatever. And all of a sudden you start the cardiomems device, if you had it in, says, oh, there's a couple of increases in pressure here. Your fluid is starting to build up. Who knows why? It just is. That's how heart failure works, right? We may have had a salty meal or something happen, but nonetheless, your pressure is starting to go up. You don't even know it. You have no symptoms. You feel fine. So a few days go by and your heart, unknown to you, is starting to get overworked. You might start feeling a little short of breath at this point. You might come up the steps and think, whoa, I'm really short of breath. But you don't think much of it and you continue on. So now you're at about 20 days that this fluid buildup is going on. And your signs and symptoms are getting worse. You're starting to get swelling. Now you see the scales start going up. You've gained a couple pounds and you're really short of breath at this point. And so that's about the time most patients will call their doctor and say, I've got a problem here. And the doctor will say, oh, wow, we really need to get on top of this. And they'll give you a great big dose of Lasix and try to get it under control. And sometimes they're just not able to do it with oral medications and they need to hospitalize you for IV medications. All right, now if we replayed that with cardiomems, on literally day 1 or 2 of this, the cardiomems would have picked up that your pressures were going up. and your doctor would have given you a phone call and been able to make a very small change and avoided all of this. And, as we talked about earlier, with all of this exacerbation, when your heart is taxed so much over these 28 days or 30 days that we talked about, it taxes your heart and it puts stress and pressure on it, which is just going to make heart failure get worse faster. So our goal is to keep it under control and to keep making small changes in medications. And that's what the CardioMEMS device really helps your doctors to do. And so it's a great device. I think that if you are falling into that class 3 heart failure, as we talked about earlier, it might be something to talk with your doctor about. All right, next slide. All right, so we have some education that is available to you. So if you are if you're on this call, you're probably one of those people who really likes to learn about, and I'm just excited that you want to take control of your heart failure. Heart failure is serious though, and with some of these treatments, you can really lead an active life. So it's very important to connect to a clinic to understand your treatment options, like my husband who had to find a different clinician to help him with this. We do have on this abbott.com/heart failure website, a clinic locator where you can put in your zip code to find a doctor who maybe has some of these innovative devices in their toolkit to help you, or at least they can talk with you about it. But if you just want some education around this, on the right side of the screen on the bottom, I have a QR code for CardioMEMS. And on the left side is that heart pump called HeartMate 3. And if you take your phone out as we're wrapping up here and just hover your camera over whichever code you're interested in, it will put you on a education journey for about 13 days, one message for 13 days, and then the messages stop. And it just helps to educate you not only about heart failure, but also about these devices that we just talked about today. And I don't have anything more. I just want to really, applaud you for being on this call today, for taking charge of heart failure, and really encourage you to be an advocate for you or for your loved one around heart failure, because there are a lot of really amazing tools and strategies available in our modern era to treat heart failure. Thank you.
Thank you so much. So I am. Can you hear me now?
Yes.
Okay, sorry, I had a little bit of an echo there for some reason. I just want to thank you, but I know that we have some questions in the Q&A. I do want to remind everyone that you can put your question in the Q&A box and we will ask Tracy about them and she can give you her expert opinion. I have 2 questions that I want to start out while everybody's typing theirs in. First, can you explain why an LVAD would not be appropriate for a preserved ejection fraction heart failure patient? That would be the first question.
I can't give you the pathophysiology behind why we are not indicated in that group of patients, but I would have to divert that to patients' doctors to ask that question but it is heart transplant and LVAD are not warranted in that population.
Okay, yeah, that was my question. It was confusing to me because when I was listening, I was like, I wonder why you can't get a transplant if you have preserved ejection fraction, or I wonder why you can't get an LVAD. So maybe that's a question we can ask as a follow-up webinar. We can get answers to. That was just my question. I was curious. The second one I have before we turn it over to Mandy for the Q&A is, with COVID-19 having such a adverse effect on the heart, do we think that heart failure will be something that we have to look at from complications of COVID?
I think that on a previous webinar, on this webinar, I believe that Dr. Adamson, our medical director, spoke to that. And I have been reading many forums about the concern of the impact on the heart and COVID-19. And, there's just so much unknown about the impact. And I think, I believe that it's very patient specific and how the disease impacts each individual patient. I had COVID-19 and I know my symptoms were totally different than the other 3 people in my life that I know who had it. And so I do think that it's going to be interesting in the next year to see what happens in the world of heart failure. But yes, I've definitely heard that in the media and also in the medical community.
Yeah, I think it's going to be interesting in the next couple of years to see the impact that it's going to take on the heart. So Mandy, I know there are some questions in the Q&A. If you could ask them, that would be great.
Yeah, there's some good ones. So Bill says his ejection fraction is at 35 to 38%. He has a Medtronic 3-wire AICD, but the LV lead is now fractured. What does this mean for his heart failure?
I would encourage him to talk with his doctor about that. Anytime you have a fracture in your device, I think that it's time to get on the radar of your doctor and find out what's next. When this tool that we just talked about comes out, maybe he can look to see more closely at what the options are. So he does, obviously, we just talked about ejection fraction. So he obviously falls into that camp of reduced ejection fraction patients where there are, a number of treatment options available that he can talk with his doctor about. The heart failure, I work primarily with heart failure doctors. And I know that they just are, heart failure doctors are experts in heart failure. And while cardiologists and all kinds of cardiologists can manage heart failure, they really work to stay up to date on the most current and innovative treatments for heart failure. And so that's another thing we didn't talk about on this call, but I think that, like we sought out a preventative care doctor when my husband was seeking care. I think that seeking care from a heart failure cardiologist, or at least partnering with them, with your cardiologist, is really important.
Thank you. Fredonia says, a patient with an ejection fraction of 11 receives an ICD and 10 years later has an ejection fraction of 49 to 51. Does the diagnosis change from a reduced ejection fraction to a preserved ejection fraction?
No, that's a good question. I know that it can be a little confusing. It's really important. And I know I tried to do my best to explain reduced and preserved, but I know that it's confusing. It's confusing for medical people, much less for people who are not medically trained. So it does not change. The difference between reduced and preserved is all about what's going on in your heart. So what is causing your heart failure? And so that person would need to talk with their doctor and say, which kind of heart failure do I have? And again, being on the radar of a heart failure team and being at least collaborating with them in your care is really important. But no, it does not change. The pathophysiology is the pathophysiology. Whatever caused your heart failure isn't going to change. It's going to remain one or the other.
Tracy, can I ask a personal question about that? So if your ejection fraction improves that much, can you go backwards on that bucket of going from a stage 3 heart failure back to stage 2?
Yes, absolutely. So remember I talked about with LVAD, so patients who get a heart pump or a HeartMate 3 or an LVAD, what that is these patients are really sick. I mean, oftentimes, and I've had the privilege of working with and being around them for many years, and it's so interesting to me. These patients are extremely sick. They're typically, either on the transplant list or maybe they're not eligible for a transplant. And so these patients are very sick. And they put the HeartMate 3 in, and for 79% of the patients in our most recent study, the 79% of those patients went backwards on that scale to a New York Heart Association 1 or 2, and they would have been on the end of the scale prior to getting it. So they really, I think that was what, prompted me from moving from clinical medicine into working with this company, because I saw these innovative solutions that they were finally making to really change the way patients were living with heart failure. So yes, you can go backwards on that scale with the right treatments.
Yeah, that's very exciting. Bradley asks, are cardio memes widely done? How many units have been prescribed?
So CardioMEMS, it has been around for quite some time. I don't know the exact number. It's in the, 10, it's, well over, probably, I would guess it's in the tens of thousands. There have been many of them implanted. And so it's a simple cath procedure where they insert the CardioMEMS device. It's typically a same day procedure where it's inserted into the pulmonary artery. And then that's where it stays. And you lie on a pillow each day and push a button. It takes no more than 90 seconds. And the reading then wirelessly goes to your doctor, and they don't even call you if your number is fine, and they can just keep track of you. And as soon as your number gets out of the range that they want it to be, they will give you a phone call and say, hey, your number is too high and we need you to take a little more Lasix. And so it's able to allow your doctor to monitor it very closely. And again, if you're curious about talking to a doctor who is implanting CardioMEMS, the website that we had on the screen earlier, and maybe we can set it out, Andrea, after the call again, will allow you to put your zip code in so that you can find the closest doctor to you who puts those in.
Yeah, and just as a follow-up on the 2020 series of In Control, we had an entire webinar based on the CardioMEMS, and one of the doctors who runs a heart failure clinic in St. Louis, I believe it was St. Louis, discussed how it's helping him and his patients manage heart failure in like rural communities and everything, because it's such a great tool, and he doesn't need to have his patients come back in, to be monitored as often. So that is in the 2020 In Control series of webinars that's on our YouTube channel now, if anybody's interested in going back and watching about the CardioMEMS.
And one of the tools that I sent out, whoever asked that question, if you do have more questions about the CardioMEMS, one of the tools I sent out is an education pathway. And so enroll for that. It's just 13 days. You'll get a 4-minute message each day, and it will educate you around, and you can give the code, or you can have your family enroll it if they're interested in it, but it will just provide you with information around the device to help you make the decision if it seems like it's right for you.
We have one more CardioMEMS question, and then Rebecca, I am going to go back to yours because it's a good one. But Bonnie asks, if a person's EF is 25%, but she's a class 1 or 2 activity level, are they a candidate for CardioMEMS?
That would be up to the doctor. And so there are, when we have our, anytime with a device company that a device is indicated, there are certain things that, categories that a patient and symptoms that they have to fall into. So again, every situation is so unique. But I would reach out to your doctor and find out if it's appropriate for them. Or again, if they're not familiar with the device, this is where self-advocacy comes into play. If my husband and I would have walked away and said, okay, we'll go wait for his heart attack to happen, we would have been in a very different situation than we are today. But taking the ball into your own hands, now you've learned about this, that it's out there. Your doctor may just not have heard about it yet, but there are many, many doctors out there putting these devices that we've talked about today in, and advocating for yourself to find those people who are sort of on this cusp of innovative technologies for managing heart failure.
Rebecca let us know that unfortunately their local cardiac rehab centers closed, and her husband really enjoyed getting that individual attention. Do you have other options or suggestions that he could go to get exercise and that special, exercise guidance?
Oh my goodness, that is like just a person, personal, and so COVID, right? So I think that, it depends on, what's available and where you are in the country and how closed down we are. I know that, personally, my husband actually started working out at home, and he does some of the online workouts at home. He found a cardiac website that helps him with workouts at home because his gym also closed. But I think that, really finding somebody in your local area who maybe, I don't know if you could find a personal trainer, but the YMCA also, I know, typically has very heart-specific programs. And I was just talking about that with somebody today, and I feel like the gym is just as much for our hearts as it is for our mental stability as well. So I hope that you can find something, and I encourage you to keep looking But yes, I would say look into YMCAs or other groups like that who might offer something and are tailored more to heart health.
And Laura has a question. I'm not exactly sure what it was. I'm going to read it to you. She said that she had cardiac arrest, CPR with 3 shocks. And although she left the hospital with a diagnosis of heart failure, she was able to return to a normal ejection fraction. So it was apparently the cause of the heart failure to have that vigorous CPR. Have you heard that before? Is that a cause of that someone can go into heart failure because of CPR?
First of all, Laura, I'm sorry. That sounds terrible and scary. I can't, because I don't know your exact situation, I can't speak to that, what it was caused from. But, there's a number of things that can cause heart failure. As we talked about earlier in the slides, sometimes an arrhythmia can be the cause for somebody having cardiac arrest, which is why a patient would have an ICD placed. To prevent them from having those sudden stopping, your heart suddenly stopping. So that would definitely be, if you're not seeing a cardiologist yet, I would definitely be on, seeing a cardiologist, if not a heart failure specialist.
Okay. Jim asks, LVADs used to be the short-term bridge to heart transplant. So what changed with their design to permit them to be long-term use?
Yes. Oh my gosh. So much has changed. They are, so we have a new device. So HeartMate 2 sort of changed the world in terms of LVADs. And so there are some patients who have lived as long as 12 years. So there's sort of 2 buckets of patients who go on an LVAD. It's those patients who are bridging to transplant. So they just need to be on that pump until they can get a heart for them. But some patients, so say for example, they are over the age limit for what your transplant center says they would implant you. Usually that number is about 70. Well, 70 doesn't feel all that old, right? We still have a lot of life left at 70. And so now one of the other indications for LVADs is that they will put them in as what's called destination therapy, or DT. And those patients will just live the rest of their life on their device. And so some patients with HeartMate 2 have lived 12 to 13 years on their device on one HeartMate 2 pump. But now, a couple of years ago, the HeartMate 3, the newest LVAD, came out. And it has a very low profile for adverse events. So as these pumps were developed over time, of course, there was learnings that they had. There were adverse events that patients would have, and HeartMate 3 has lowest adverse event profile of any LVAD ever made. And so patients are just really living great lives, because it's not great to have an LVAD put in if you're going to have all kinds of problems, right? And so that, I think, is what has changed the game for LVADs, is that the adverse event profile is really low in for sure the HeartMate 3 device, but there are patients who have lived a really long time on HeartMate 2. So if you are at that ending phase of heart failure and you haven't talked to your doctor about an LVAD, absolutely talk to them if you have reduced ejection fraction heart failure, because patients, I can tell you a story of my 14-year-old patient. He was 14 and had a sudden cardiac arrest. He went down in his front yard playing football. He had a virus that had attacked his otherwise totally normal heart. He was on every life support machine you can imagine, which is definitely not the optimal time to implant somebody with a device, with a pump. And they put the HeartMate 2 pump in him, and he went back to living a totally normal life. As he went back to high school. Just 21 days later, he went back to high school after this terrible event. And so he went on to get a transplant. He went on to live, really nicely with his HeartMate 2. And so they are pretty amazing devices.
This is a follow-up to that. With the success of the LVAD, why do people need to wait until that last stage to get the device?
So because there's so many other options available for patients, you know, it's sort of that class 3 into class 4 group. And so it's up to your doctor, but they definitely don't want to wait until you are really, really sick to get in. Sick meaning you're in the hospital, your heart is totally failed. They don't want to wait till that point. They really want to hear from you earlier in your disease so that you can really be on their radar. And then the heart failure doctor can determine when the optimal time is for your implant. And so that is something they want to hear from. I think it's the number one complaint of our transplant centers is, gosh, we just get these patients so late in their disease that it's too late for us to do anything. So, you know, again, I can't say enough. If you're not seeing a heart failure specialist, please do get on their radar because they have the tools in their toolkit to help you.
I think we've got 2 more questions I can see. Thomas asks, what's the range of numbers for PA?
It's variable. It varies from in men and women. So I would, I mean, I can't tell you off the top of my head what normal would be. But, you know, what I would do is, I mean, you can Google what normal would be for a man or a woman. But again, it's very dependent on your heart failure. So if you're living with heart failure and your PA, you know, that would depend on where your PA falls and what your doctor would consider something that they would want to intervene.
Okay, thank you. And Jim says, if you are not suffering from a worsening condition, is your arterial pressure still gradually increasing?
Read that again, please.
If you're not suffering from a worsening condition, is your arterial pressure still gradually increasing?
I don't really understand that question, but let me answer it the way I think it's being asked. So PA pressure increases when the fluid starts building up it backs up from the heart, builds up in the lungs, and then it starts to increase in your PA. And so anytime that, and like I said, with CardioMEMS, what's really interesting is that you can start seeing that fluid build up when it's just starting. Because the pressure starts backing up in the system. It's really just a connected system that pressure starts building up. So it can be a variety of things like, you know, say for example, you have a CardioMEMS in and you go to a barbecue and you have, you know, some fried chicken, you know, maybe they've got some sausages there and you're just like, I'm going for it today. And you have one of everything. And the next day, your doctor might call you if you have a CardioMEMS in and say, whoa, what happened? Because your pressure would be, the pressure would be so sensitive that it would identify that, that the pressure went up in your pulmonary artery just from that behavior. So it's pretty sensitive. And so that there can be a number of things that can cause it to go up. But it's very sensitive. And so you can see how carefully your doctor would be able to manage your patients if you have that device, or your medications if you have that device in.
Can you just, Bonnie wants clarification on what does PA stand for?
Pulmonary artery.
Thank you. And I think that's the only, that's the last of the questions. We had a lot of them. People had some great questions.
Yeah, thank you all so much. And Tracy, thank you so much for spending this hour with us. We truly appreciate your knowledge and all of your information. For everyone listening, we will send out the recording of this webinar and with the handouts that are in the chat that you can download. So if you weren't able to access them or you want to get them to share with friends or family, no worries, it will be coming within the next day or so. And then I just want to make sure that everybody is aware that next Thursday at 2:00 Eastern time, it will be the second webinar in our series. And this one will be the symptoms you should not ignore. And I think this one is going to be great because sometimes we don't know that the symptoms are indicative of heart failure and we just think that it's just because of aging. And so it's really important for us to know in advance what to look for and which ones we should not ignore. So thank you all for joining us. Tracy, thank you so much for spending your time with us. And everybody have a great day.
Okay. How was that?
Good.
Are we going to get the handouts?
You can get the handouts, yes, on, they are, let's see, where do I want to go here? They are online. You can get them, as many of them as you want, by going to mendedhearts.org/in-control, and you can pick them up. Let's see.
Thank you.
Okay. So here they are, cardio meme, the education brochure, and then this is information on the LVED, the HeartMate 3, the brand new one she was talking about. And then this is the information that she put on those slides between this one and this one. Heart failure basics and heart, let's see, I want to stop sharing. So, okay. Okay, well, some good questions that I'm going to do a screenshot of so I can take them and send them over to Tracy from us.
Laura, just a comment. You don't have to send that LVAD question to Tracy. I just didn't know what that was. So
Okay,
I'll just Google it.
okay, well, I think your other question is really good. Why do doctors check and measure the percentage of blood flow? Or how do they?
How? Yeah, how?
Is Lorraine, are you still with us? Oh, well, I would love to see if this answered her questions about the HeartMate 2 and the HeartMate 3. So I'm sorry, I think she had a client she had to be with, but I'll get back to her on that. Wasn't that amazing? Can you imagine your cardiologist saying, "See you at your next heart attack"?
Bad.
So and that's because the monitoring has gotten so much better. You know, it used to be just put on your blood pressure pump and watch your weight. And now there's a better way. So I just thought this was fantastic, especially and that how prevalent heart failure is.
I have a question. Is Tracy an employee of Abbott?
I believe she is.
Yeah,
No,
I believe she is too. Just a
that's
question.
That's a very important question to ask. There may be additional resources that we don't know of from other providers.
Well, I thought she was pretty clear when she said at the moment, they're the only ones that are doing that or, have that device. There may be others who are working on it, but they're not there yet. The other is sometimes I've discovered that the employees of the companies that are making these devices actually know more about the devices than anybody else, including doctors.
Right.
And of course, talking about it may get them into trouble. But I especially liked her including us in her journey with her husband at 51 who had a heart attack. And then it was just, well, I say just, but coronary artery disease, and that they expect to see him again without saying, oh, there are other things you can do. So that's why I am so grateful to these informative webinars that we can ask all of these questions, of our own people and find in my case, find a heart failure specialist and ask about things. And one of the questions I'm going to ask Steve is, how do doctors check and measure the percentage of blood flow?
Yeah, that was new to me. I don't recall that in any of my previous conversations with my doctor. So I just was curious, how do they actually come up with those percentages? They obviously have to use a device of some type to measure the blood flow, but
Well, I know, did you ever have one of those things you had to blow in?
oh yeah, all the time.
Yeah. So that was what they were telling me, is that, when I couldn't get it up very far, it was like this instead of like,
Yeah,
that that's what needed to improve before I could get off all of the many medications.
right, yeah.
Does Kaiser have a heart failure cardiologist?
I'm going to be finding out.
I'd be interested in knowing because they've never identified that as possible.
Okay. Let's see. What is your email address?
Rena, RENA SCH 80 @gmail.com.
Let me see if I can read that back. RENASCH 80
That's right.
@gmail.com.
That's correct. Thank you.
Sure. Yeah, I'm very happy to share anything I find out.
Because I don't even have a cardiologist now.
Uh-oh.
Yep, exactly.
Oh, were you one of Terry Anderson's patients?
I was.
Me too. Me too.
Yeah.
Wasn't she
She-
wonderful?
She was great, but she decided to retire.
I know. Well, I went with O'Reilly, I think is his name.
Well, I had Dr. Killebrew after that, but she also retired.
You gotta find the young ones.
Yeah.
Yeah, right.
No, seriously,
she-
when I'm looking for anybody anymore, I make sure that they're significantly younger than I am.
Yeah.
Yeah, for me, that doesn't take much.
Hey, go for it, Rena. Hurry up.
Right. Because I ain't that young anymore.
Well, I would recommend the other 3 in this series. And if you notice, she referred us back to that previous In Control section, the 2020 In Control, which is also on that same website. So
Okay.
you can find all of these to get some more questions answered. But I really liked those questions because she shared more about the specifics that I needed, because I don't know heart failure. I don't know
I've
anything.
never heard any of that stuff. Never.
I know.
So
So
Laura, we thank you very much, but I think it's getting to that point where we got to call it a day for everybody's sake. Many people have things they want to do. Steve has already dropped off.
okay.
And it has been recorded. I guess some editing will have to be done, but should be up in a short period of time. Thank you.
Okay.
Thank you all.
Thank
Thank you,
you, everybody.
Thank you.
Thank you, everybody.
See you in July. I mean, in August.
That's right, Catherine. I hope you enjoyed your breakfast.
Good catch,
I
Rena.
did indeed.
Good, good.
A healthful breakfast.
Excellent.
Okay.
Good old oatmeal.
Okay, have a good day.